Just to remind everybody, I know some of you already put in loads of information onto the chat. Do use the chat. We've got people from the OT service online ready to take your chats, and also from Closomat as well. So keep them coming throughout the presentation. Don't feel you have to wait to the end of the presentation. However, we will be doing a Q&A at the end as well. So if you feel as though your question hasn't been answered throughout the presentation itself, then do use they at the end to pass across your questions that you've got. So just a reminder to people, our next webinar will be on Thursday, the 24th of March, and it's the impact of neurological trauma on bathroom activity. So and Kirsty from Closomat will put the link to that now, but also at the end as well. So you can log straight in there. I can see it now myself. So you can click on that and register from today for that webinar that's in March. Okay, so without further ado, I'd like to introduce the presenters today. So we've got Ray Rochester from Closomat. Ray is new to our business, although new but old. He's been working for Closomat previously, so it's great to have Ray back in the business. And Ray will take you through a little bit around our products, a quick summary on those. And then I will now hand you over to Lucy, who'll take you through the main content for today. Thank you.
Thanks, Stephen. Hello, everybody. My name's Lucy Leonard. I am an associate occupational therapist with the OT service. And I'm delighted to be able to speak to you about the topic today. I worked in paediatrics in the local authority for a number of years. And I felt really privileged to be able to work with children and young people to support their development and independence and facilitate their occupational performance. So I'm going to use some of the experience that I had from my time working in the local authority. I also work independently with children and adults, again, mostly in equipment and adaptations. So it's a little bit about me. I don't want to talk too much about myself because I really want to get through this presentation. There's a lot to get through and there's not a lot of time. So please ask any questions in the chat box. My colleague Adam from the OT service is on hand to help out. So just quickly go through the learning outcomes. Basically, we're going to be reflecting on the impact of occupational performance on a number of paediatric specific health conditions. We're going to be looking at occupational performance and looking at the impact on the environment and independence. Just touching a little bit on clinical reasoning and legislation to help us to guide us when we're making recommendations. And then I'll be looking at a bit of equipment and adaptations in the bathroom to maximise potential. So it's really difficult to choose which paediatric conditions to cover today because obviously we see such a range. But I've chosen some that I came across that were particularly interesting or challenging. So we're going to be looking a little bit at global developmental delay, muscular dystrophy with a focus on Duchenne's, and autism, which I found that the number of children that I was seeing with autism was increasing over time, especially with sort of difficulties with behavioural challenges, and also spina bifida, because that is quite a complex condition. So I love this quote: the unique contribution of occupational therapy is to maximise the fit between what it is the individual wants and needs to do and what is his or her capability to do. And I feel that that's the unique position that occupational therapists hold. So we look at what somebody wants or needs to do or is expected to do as part of a normal daily life, and we look at what their capability is, and we assist with improving their occupational performance and working with them on their goals. So I just really like that quote, and it just focuses this presentation on what I'm trying to get across today. So when I was looking at putting this presentation together, I always go on the Royal College of Occupational Therapy website, and I would encourage you to do the same. There's an absolute ton of information on there. And if you are looking to do a little bit of CPD, or if you've got a little bit of time, just go on and have a browse through some of the documents that are on there. This one is particularly helpful. It's about unlocking the potential of children and young people. And it was produced alongside their campaign, which just says in the bottom there, #ValueOfOT. And I know the College of Occupational Therapy did a lot of work about improving lives and saving money. And this was one of the documents that they produced. So I've taken a little bit out of that document and just again to focus us on the presentation today. So one of the things that the college was saying is that occupational therapists should adopt a strengths-based approach that fosters self-management and independence. So I think that's really important that we take that approach with children, and even if they live with carers and parents, we should be looking at self-management and independence as a focus and a target of our assessment and intervention. Again, just picking out something else in that document, we need to realise the potential of children by developing the skills and resilience they need to access not only education, but to perform those activities of daily living as children and as adults. So I really feel that even though we may be working with children, we should be looking at them as an occupational being, as somebody who's going to transition into adulthood. So we should not only be addressing their current needs, but thinking about them as an adult and what their needs may be and how they may change. And finally, it's really important for us to enable children to lead full and happy lives, participating in those occupations that they need and want to do at home. So I just found this a really good document to reflect on and to focus the content of the presentation today. So just starting with the first condition. So what I'm going to do is I'm going to talk you through these conditions. I'm going to give you some of the signs and symptoms, and then what's more important to me as an occupational therapist is the impact of those conditions on function and occupation. So global developmental delay is often abbreviated to GDD, and it refers to when a child takes a lot longer to reach milestones than age-related norms. And this isn't about children developing at different rates, but this refers to a number of issues occurring simultaneously, because we know sometimes children can be crawling early and some of them don't move until much, much later. But this is more about a number of issues occurring together to allow clinicians to reach that diagnosis. Global developmental delay might be significant, and actually what may happen is the child never really reaches those age-related norms despite intervention from occupational therapy and physiotherapy and our colleagues. And global developmental delay is usually related to another condition such as Down syndrome or cerebral palsy, but it can be related to other, sometimes rare disorders. I know from experience, I've worked with a number of children that have some quite rare disorders which present as global developmental delay, but that's not actually their primary diagnosis. So for me, it's important to know what it is and understand it, but actually it's about that individualized assessment and the impact of developmental delay on function. So thinking about the impact on function, it can be far-reaching and impact on all aspects of cognition and social and physical function, and it can affect things like social interaction, managing emotions, language, things like that. So in one way, it's going to have a major effect on a child's independence. And because the child is developing differently from their peers, certainly if they go to a mainstream school, that can affect their confidence because they will start to notice differences in their ability as compared to their friends and peers. And the complexity of global developmental delay presents itself as a combination of those cognitive challenges together with fine motor or gross motor difficulties. And that's why it's absolutely essential to do that really careful and detailed assessment of the child and personalize any intervention. So you're making sure that you're addressing their specific needs. So just moving on to muscular dystrophy, there's kind of three types, and I'm very much going to concentrate on Duchenne's because that's what I've got most experience of, and that is absolutely the most common type. Duchenne's muscular dystrophy usually shows signs at around ages 2 to 3, and it usually affects the lower limbs first, and then later on it will affect upper limbs and respiratory muscles, including the heart. There's a different type called Becker's muscular dystrophy that appears a little bit later, so the signs and symptoms appear a little bit later on. It's got a much slower progression than Duchenne's, and it can usually affects the hips and pelvic area first. And then the limb girdle type, there's lots of different forms of this, but it can either start in childhood or as an adult. And again, it's about the main symptom is muscle weakness. And then the progression is related to the age of onset. So if we concentrate on Duchenne's, because that was I found it really challenging when I worked in adaptations for children. It mostly affects, you're probably aware, it mostly affects boys. There's 100 boys born with Duchenne's every year, and there's about 2,500 boys living with the condition every year. And as I said, the symptoms start quite early on, and the ability to weight bear deteriorates to the point where the child will be reliant upon a wheelchair for mobility at around 12 years old. That can change from person to person, but it's usually around the transition to secondary school, which brings its own difficulties. And I think what's really important is when we are asked as occupational therapists to become involved with children with Duchenne's, that we are forward planning, that we are thinking about their future needs as an older child, as a young person, and as an adult. So I think it's really important to work with the family to future-proof and to look at future needs. And with Duchenne's, the heart, because the heart is a muscle, is eventually affected, as well as the intercostal muscles, which leads to breathing difficulties. And unfortunately, it is a life-limiting condition with an average life expectancy of around 30 years old. So thinking about the impact on function, because again, regardless of what the condition is that a child has, what we're interested in is how it affects their function and their daily occupation. So obviously with any disease that affects muscles, they're going to have difficulty with general mobility. So it might start with things like climbing the stairs, walking, transferring, and that might lead to an increased number of falls. And then as the disease progresses, it then starts to usually affect the upper limbs, and then that has an impact on daily activities, which affects children's ability to participate in school in terms of writing. It can affect things like personal care, so washing, cleaning teeth, brushing hair. And sometimes Duchenne's can be accompanied with a learning disability. So we need to consider that if we are working closely with children and looking at altering the occupation that they're doing and asking them to do things that their learning disability might impact on our ability to get them to change the way that they carry out occupation. And I keep saying it, but it's so important to consider the impact on their future needs. Okay, so autism spectrum disorder. I saw an increasing amount of children with ASD in my role. A lot of the children had behavioural problems in terms of keeping themselves safe at home. So I would work very closely with the families to look at changing the environment to keep children safe. And we all know that it's on a spectrum, isn't it, autism? So symptoms can range from really mild, so somebody can have a diagnosis of autism which is mild. They can live completely independently. They can go out and have work, be able to work and live a normal family life. But then we see the other end of the spectrum where children and adults can be severely challenged and require significant support in their daily life, in every aspect of daily life. The signs and symptoms usually appear by around age 2 to 3, although it can be diagnosed earlier. And I mean, you can go and read about autism. I've just got a few of the signs and symptoms here that health professionals will look at. And again, it's about a combination of symptoms and signs rather than a blood test that assists with diagnosis. So it's things like a child will not play games with turn taking by 60 months of age, lining up toys and other objects and getting upset when the order is changed, repeating words and phrases over and over, and I've seen that a lot working with children with autism, playing with the toys the same way every time, so no flexibility of thinking, very focused on parts of an object. So when they're playing, for example, with a car, they'll be very focused on the wheels rather than the car as a whole. Children having obsessive interests in particular things, having to follow certain routines, things like flapping hands, rocking the body or spinning in circles, delayed language skills and delayed movement skills. I mean, that's just a very small part of what a clinician will be looking at to make an autism spectrum disorder diagnosis. Okay, so mainly the things are around communication problems, restrictive or repetitive behaviours, delayed language, hyperactivity, and impulsive or inattentive behaviour. So the impact on function, and I've seen a whole range of children with various different levels of autism. And I was thinking about the children that I've worked with and the impact on their sort of bathroom activity. And they sometimes are inclined to focus on details rather than the entire task. So, for example, a child who wants to have a shower and as part of a daily routine to get washed may completely focus on something like the water coming out of the shower head and the feeling of that, or watching that, and actually would stand in the shower and watch this for as long as they could without focusing on the task, which is getting a wash. So that can be quite challenging, and children with autism often need continual prompting or even physical prompting to remain focused on the task. And if they are able to focus on a task, they might have difficulty in recalling how the task is performed, which again will lead to them needing constant prompting. And then there's the challenges again are around that combination of the effect on decision making, divided attention, and maybe those visual memory and motor skills that are affected by autism. So they might actually need reminding that tasks need carrying out. So getting up in the morning and focusing on a small aspect of their daily life, they might forget that actually they do need to get up and get washed and get dressed. And I really felt that when I work with children with autism, the cooperation and understanding is the most challenging thing for me, because with all the will in the world, you can adapt the environment, you can adapt the occupation that you want them to perform, and you can even look at making changes to them and how they do things. But if they're not cooperating or understanding, I found that made intervention most challenging. And I found this infographic, I actually found it on Facebook, and I thought it was brilliant. And we talk about the autism spectrum, and I think clinicians, occupational therapists, members of the public, we think of it on a scale from less autistic to more autistic. And actually what autism looks like, and people who work with children with autism will understand this, that it's a combination of those abilities that can change from individual to individual. So you may have a child who has fantastic language skills, goes to a mainstream school, has great motor skills and sensory skills, but struggles with perception and executive functioning. Or similarly, you might have a child who is non-verbal, but their executive functioning is really high. So it's really important when we think about autism is not to see it on that linear spectrum from less autistic to more autistic, and see it like that diagram shows at the bottom, that children have challenges in different areas and also skills in different areas as well. And I think that's where the assessment comes in, is to understand from the child and their parents where their skills and their strengths lie. Okay, the final thing that I'm covering, I'm just checking the time, is spina bifida. And this is a really complex condition. So again, we're just going to touch on it, but spina bifida actually just means split spine. So it's about, it's when the spinal cord doesn't form properly. And the most common type is spina bifida occulta, which is the most common, but also the mildest form. And there's typically no signs at all. It's usually diagnosed when somebody has an imaging for another reason. So they may have an X-ray on the spine, and then it's found that they have spina bifida. And then myelomeningocele is the most severe type. It affects the spinal canal, and the spinal canal is basically open along several vertebrae. So the membranes and spinal cord can protrude at birth, forming a sac, and this sac is sometimes covered with skin. And it causes further complications such as scoliosis or dislocation of the hips and muscle contractures. There's 2 slides on the impact of function, because spina bifida affects cognitive function because the cortex may be thinner and the cerebellum may not form fully. So it affects a person's or a child's executive functioning. So basically they struggle to imagine the future. So that can affect decision making. It can affect things like motivation, organization skills, planning, attention, and switching between activities, and also that ignoring distractions. And then physically, the children with spina bifida may also have hydrocephalus, which might need a shunt fitting. It usually affects the lower limbs in the form of paralysis. It can, because it affects the lower spine, it can lead to incontinence of bowels and bladder, leading to increased bladder infections. And also because of the loss of sensation in the lower limbs, they can have problems with skin integrity. Children with spina bifida often have sleep disorders, and there is a higher risk of a latex allergy. So this presentation is about the impact on bathroom activity, and I thought it was really important just to touch on an assessment. And we often use the term holistic. We say we're occupational therapists, we're holistic. So we do need to cover in our initial assessment things like sensory needs, the culture and the values of the child and the family unit, which I'm really interested in, is about not only understanding the child, but where the child fits within that, the culture of that person's home and what their values are. We need to build a rapport with the child and with their family or their next of kin. We need to understand their needs, wants and goals if they're able to verbalise that, or work very closely with their family to understand what their goals are for their child. Obviously, we gather information on their condition and their signs and symptoms and their cognitive abilities. But what we also should be looking at is the age-related norms of that child. So when we're working with children, we should be in a way comparing what they're doing now to what are the age-related norms, and actually facilitating those age-related norms. So for example, if a child is still being assisted to the toilet by a parent at age 10, 11 or 12, we have to ask ourselves, is that an age-related norm? Or should we be looking at, as much as we possibly can, facilitating the independence and dignity of that child and supporting those normal life roles where an adult or a parent will look after a child, and then as the child gets older, they become more independent. So the question is how can we facilitate the child to undertake those age-related norms? What can we do? So if we think about toileting, there's very simple interventions that we can undertake to assist them with toileting. So for a child, maybe with developmental issues or with autism, we can do things like sticker charts. We can do the pictures for a child to follow and stick that in the toilet and get them to, you know, take the trousers down, sit on the toilet, and you can see that little those graphics there about flushing the toilet and washing their hands. So really simple intervention can assist with independence and age-related norms. And then there's other activities that you can do with children. So if they're having difficulty reaching round to wipe themselves, you can get stickers and you can stick them on different parts of their clothes and get them to reach them. And can you reach the stickers in certain places? And that encourages children to improve their range of movement in the upper limb and get them practicing wiping without actually doing it. And then there's other things that you can do, like using Nutella on you know, some plastic and get some tissue and wiping it, and just getting the child who may have sensory issues used to dealing with tissue and making things clean. So they're just some really, really simple things that we can do as occupational therapists to facilitate occupational performance. So when we're working with children, and this is my go-to model of choice, to be honest, but when we are working with children, we're looking at the person and we are looking at the occupation that they're expected to do, for example, toileting or bathing, and we're looking at the environment in which they're doing that. And as occupational therapists, we are looking at facilitating that occupational performance. So those things that I suggested about the stickers and the Nutella, that is looking at the occupation and trying to facilitate that and change it and get the child used to doing that. But I'm going to focus now on the environment and how we can change the environment to facilitate occupational performance. So there's various different ways in which we can look at the environment at home, and children that we work with will be on a spectrum of how dependent they are on others for assistance in occupational performance. So for example, toileting, we can put equipment on the toilet or over the toilet to assist with their posture. And this example here is a wash-dry toilet. So you could push the child over the toilet in this instance on this toilet seat, and they would be able to use the toilet and hopefully manage their own personal hygiene after using the toilet. And obviously there's different postural needs for children. There's things available to allow them to sit in a functional position. And then older children who may struggle with transfers can have other equipment to assist. This is something called the aerolet, which I have used, and I've got a case study I'm going to touch on with older children, and you can get a junior insert, so a different seat to put on that to help children to transfer on and off the toilet. So I'm just looking at the time. I am going to do a very quick case study. I could talk about this all day. So I'm going to use a couple of the conditions that I've discussed today already. So very brief case study is a boy who's 12 with Duchenne's muscular dystrophy, and his mobility is deteriorating, but he really enjoys gaming. He's very tech savvy, He uses Alexa for his lights. So in the morning, he can sit in bed and ask Alexa to turn the lights on and to play his favourite radio station. He lives in a dormer bungalow. There's a bedroom on the ground floor, and adjacent to the bedroom, there was a storage cupboard. And then next to that, there was a ground floor toilet. So the occupational therapy assessment really focused on his goals, promoting his occupational performance, but also looking at future needs, because we know with Duchenne's, the deterioration will happen over time. But just going back to the PEO model, and this can sometimes help to focus your assessment. So what I did here is I looked at the person. So I looked at the boy that I was working with and his goals, and he was able to express his goals. I looked at the environment in which he was living in, which was the dormer bungalow, and I looked at the occupation that he wanted to engage in, which was toileting and washing. So when I met him, his ability to use his upper limbs was deteriorating as well. So what I did was looked at changes to the environment, and what we did was, using a disabled facilities grant, created an ensuite bedroom for this boy. And the ceiling track hoist was an H-frame, which went through into the bathroom into another H-frame. We put in a wash-dry toilet for him, so he was able to be hoisted onto the toilet and left in there to use the toilet independently. He had the touch-sensitive switch, which allowed him to press it once, and it went through the whole wash-dry cycle, so we didn't have to press and hold anything. This boy had a mild learning disability, so the simplicity of the wash-dry toilet and just the ability to just press one switch and for it to do everything for him made a massive difference to him and his independence and his dignity. We also looked at putting we also put a height adjustable basin in. So what he would do is wheel into the bathroom, and he could prop his forearms onto the height adjustable basin. And then by doing that, he could still clean his teeth and wash his face. He had a shower chair, which was slightly tilting space, but it would be likely that we would be looking at a shower stretcher in the future. So another quick case study, autism spectrum disorder. This was a boy who was 17 and he goes to college. He lives at home with his mum and dad. He was really, really fixed with his routines, and I met him during lockdown, and it had been extremely difficult for him and his family. It was a really challenging time because his routine had just disappeared. Mum was really upset that he wasn't able to wipe properly after using the toilet. And because he was 17 and very fixed and wanted to be independent, he was refusing help. And actually, I've put there, you know, is it age appropriate for a mum to be assisting a 17-year-old with wiping after using the toilet? Well, it isn't. So, you know, as an occupational therapist, I'm looking at supporting mum's life role and supporting his independence and his dignity. But what was happening was he was having problems with hygiene because he wasn't wiping properly after opening his bowels, and this was causing a lot of distress with mum. And yeah, it was a very difficult situation because he wasn't aware of the difficulties that he was having. So mum had never heard of a wash-dry toilet. She didn't even, it was one of my colleagues that referred to me, and she was absolutely delighted, the thought that her son could go to the toilet and actually she would know that he would be clean and dry after using the toilet. And actually, when I spoke to this boy, young man, he really wanted to live independently, and he spoke to me about getting his own flat. And this family were fortunate enough to have a downstairs toilet and upstairs toilet. So we talked with him about where he wanted the toilet putting. And so we agreed with him and the family that it would go in the downstairs toilet and it would just be his toilet. And that was really important to him. And I felt that was kind of a graded approach to him living independently. So that was a really nice outcome. And what happened was he had a few sensory issues. So working with Closomat, we were able to install the toilet and adjust the spray, the power of the spray, so we could increase it over time, and it worked really, really well for him, and Mum was absolutely delighted. So I'm just going to have to wrap up pretty soon, but just thinking about our clinical reasoning, because I know sometimes it's quite challenging for people to request adaptations, especially if there's a significant cost. But we need to remember that with our clinical reasoning, we need to be looking at what is necessary and appropriate in terms of a disabled facilities grant. And also we can use things like the Children's Act 1989, which says no child should be affected by their sibling's disability. And in our code of conduct, which I always use and think, well, we should be working within our code of conduct, we need to make recommendations based on the choices and aspirations of the people who access our services. So it's not always about criteria and budgets. We absolutely should be looking at what the choices and aspirations are for the children and the families that we are working with, and that's really important, and that is in our code of conduct. So regardless of budgets and having to write supporting documents to ask for DFGs or equipment, we absolutely should be acting as advocates for the people that we work with, because it's in our code of conduct. What we should be doing in every intervention is promoting greater occupational performance, and obviously all the time considering those moving and handling risks, and reducing the risk for the child and their family. So it was a whistle-stop tour, but I want you to take away that as autonomous and holistic practitioners working with children, we really should be focusing on occupation and improving occupational performance and facilitating children to engage in those age-related norms, regardless of their illness and disability. So consider what condition they have, but it's more about the impact on occupational performance and the impact on function that we are interested in. I'm now going to hand you over to Ray, who's going to talk you through some products from Closomat.
Thank you very much, Lucy. My name is Ray Rochester. I am the Regional Sales Manager with Closomat, as Stephen introduced earlier, back here for my second stint after being here for 6 years up until 2016. In the next few minutes, I just want to give you a flavour of Closomat, the products and the service, so that you can understand what drives us and how we can help. It is our belief that dignity and independence are fundamental to a person's well-being, and we as a company strive to do our very best to allow everyone to live their best life every single day. Closomat have been well known for wash-dry toilets, as Stephen said, for almost 60 years, but few people realise that through our partner companies such as Lico Hillrom and Pressolit, we can also supply and install a range of other products such as changing places, changing benches, hoists, shower seats, and wash hand basins, drop-down rails, and body dryers as well. They all complement the Closomat toilet in the bathroom environment, as I'm sure you appreciate. Closomat toilets have been designed with less able people in mind, with a range of accessories that we can use, such as alternative operating methods, plinths, and seating options. Closomat toilets can be adapted to suit people with a wide range of needs and allow them to operate the toilet to achieve a hygienic toileting solution in an easy-to-use fashion. Closomat toilets use up to 8 litres of water a minute to wash, and therefore provide the most effective wash and dry solution on the market. The toilet, as standard, has a weight limit of 30 stone. And as you can see on the screen, there's talk of Palmer Life 10-year service and warranty. I'll talk about warranty in a few moments. So, how do we support you? In dealings with Closomat, we take responsibility away from you for the whole process, as it says on the screen. This includes doing the client assessment, either with you or independently. This will typically result in a product specification which is specific to that individual client and their particular needs. Where necessary, we will also carry out product demonstrations and installation surveys. Excuse me, sorry. So installation surveys, which will enable obviously us to be ready, or a contractor to be ready, for a very prompt and efficient install when the time comes. Closomat also offer a no quibble guarantee. So as long as we carry out an assessment, we guarantee the specification of the product will suit the client's needs. If for any reason the specification is not correct, we will make the adjustments at no additional cost to yourselves. With regard to assessments, client assessments, from the simple to the complex, or anywhere in between, come to that, we will carry out on-site visits or remote assessments, taking into account the client, their abilities, their needs, as well as the transfers and the conditions in the client's property. Those conditions in the client's property include the condition in the bathroom, the access from the front door or from the entrance to the property all the way to the bathroom. Any on-site assessments are always carried out in accordance with our COVID risk assessments, ensuring that the client, the professional, along with ourselves, our colleagues and our families remain safe at all times. Following the assessment and the order, we then take full responsibility for the installation. We have a team of employed installation engineers that we use where we're providing the installation. If, on the other hand, a local authority chooses to allocate the work to another contractor, then we provide a full range of support and training to those third-party installers so that the service that's received is absolutely seamless. We take responsibility for commissioning. Commissioning, sometimes referred to and more commonly referred to as a customer care visit. These are carried out following every installation of a Closomat, approximately 10 days after install. There's a couple of purposes to the visit, one of which is to check the installation and make sure that the installation is correct and the Closomat is working correctly. But more importantly, and the customer care part of this visit, is about how that client uses and interacts with the Closomat toilet. So we'll have a conversation with the client or with their family or with the carer, and we will make adjustments to the toilet after that. We can change the water pressure, we can change the water temperature, the wash time, or the dry time, and in some cases, the method that is used to operate the toilet, so that there's a more comprehensive solution to the client using the toilet and they get a whole better experience. In recent times, we've made the process of recording installation details more efficient by using QR codes on packaging and product to enable the installer to register the installation quickly and easily. Service and warranty, as I mentioned earlier on, following commissioning, if there are any issues with the function of the Closomat toilet, we use our nationwide network of employed engineers to make an effective repair. If it's also been ordered, we will also provide annual services on the toilet. They will be done along with ongoing breakdown cover. These can typically be for 5 years, or in the case of Palmer Life, as you saw on the earlier slide, up to 10 years from the original installation. In the same way that servicing your car keeps it running smoothly, annual services visits ensure that the Closomat is in the optimum condition to ensure that the client continues to enjoy the best possible wash-dry experience, and this protects the asset for the local authority as well. Servicing by Closomat is proven to extend the product life and also reduces future spend on equipment provision for replacement, for example, and takes away the need for visits by other contractors or professionals such as yourselves. So once you buy from Closomat, you're done, essentially done with worrying. We take most of the responsibility away from you to ensure that the right specification is supplied, installed and maintained to give you the best solution for the client, the local authority and yourselves. Thank you for watching and listening. I will now pass you back to Stephen Edwards to take you through to the Q&A session. Thank you.
Brilliant, thank you, Ray. Again, as always, a really insightful sort of 10 minutes into our product range. But do, if you need more information, I'll go through a couple of the links for you, but do contact us at any time if you need more information. So I'd also like to thank Lucy. I think in terms of what Lucy's gone through today, as she already mentioned, to do that in half an hour is an extremely difficult task, but again, extremely insightful, and to get across what she did in 30 minutes is fantastic. So as in terms of the next slide, Ray, if you could just boost it on, that'd be great. Just to sort of remind people again of our next webinar, which is in March. And I know Kirsty, colleague, has put the link on there in terms of for the next webinar. what I'd like to do now is really just open it out to all of you. If there are any questions that haven't been answered, and I'm sure I've been looking at the chat, there's been a huge amount of chat as always, and I know the team have been busy to type that chat up as quickly as they can, but just wondering, I can open it out to the whole team. Just wondering if there's anything that you guys had picked up that is worth sharing with everyone, really. I think, Adam, you've got a quick...
Yeah, I'll dive in with a question. I picked up 2 questions, but I'll dive in one if that's okay. Firstly, Lucy, it was really difficult to catch up with all the questions and answers because I was so engrossed in the presentation myself. Thought it was absolutely brilliant. So from an OT to OT, thank you very much. There was one question that I thought would be really useful for everyone, and there was one about sensory needs and what we might recommend to use in a case where the child can't tolerate water from a sensory perspective, and whether you've got any advice about that. And the second one was any strategies or equipment where the child is away from home, so accepting that we can solve that issue with something like the toilet or adaptations in the person's home. But because as occupational therapists we're covering holistic activity, what the challenges or opportunities there are outside of the person's home.
Yeah, absolutely. Firstly, with regards to the sensory issues, I would take a graded approach because I've actually had this with a number of the children that I've worked with, and it can take a long time. So before installing a wash dry toilet, if that's, I presume that's what the person was referring to, we would get the child to play with water, to understand water, to get in the shower, maybe spray the shower, you know, at their bottom and things like that, just to get them used to that feeling of water. So very much it's about a graded approach. And as I mentioned briefly in the presentation, Closomat, you know, like Ray said, they're with you all the way. So I was able to work with my local product specialist and, you know, sort out the fact that when the wash dry toilet first went in, the spray was, the power was turned down. So it was just about that graded activity and just getting the child to sit on it and press it and just feel that water. And even if they jumped off, that was fine. And then just take that time and just say to the parents, you know, this isn't going to happen overnight. This could take a while, but actually it was actually a lot quicker than we thought, because you can take a very a playful approach to it to support the child. So that's what I would say is a graded approach. With regards to out and about, it's a difficult one. I think society is changing. I'm very interested in the social model of disability. If anybody wants to go and have a look at that, it's something that I'm quite passionate about. The fact that society isn't really geared up for everybody. And I know with changing places, there are more wash dry toilets going in. And so what I would say to people is if their child is struggling, to try and access a changing space where they often have a wash dry toilet in, to enable the child to be independent. That would be something that they could look at.
Thank you. Yeah, changing places was one of the things I mentioned in the answer. It's just, we're still in that challenge, aren't we, of then people having, at the minute anyway, and like you say, things are changing, and the access to changing place facilities is definitely growing. But ideally, we want to be in a position where people aren't having to modify their routines around where there is a facility, don't we? So at a point where they can freely choose activity whilst continuing to have those facilities wherever they may be, rather than having to be active around where those facilities are.
Yeah, I mean, you can still get bottom wipers and things like that for not very much money, and they have their place. I know many years ago, you know, we would say if you can manage with a bottom wiper, you know, that's it really. But obviously things are changing, but maybe just a simple piece of equipment and assist the child in using it, and then when they're out, get them to use it independently, may be a way forward.
Thanks, Lucy.
Yeah, that's great. Robin, I didn't know whether yourself or Kirsty could send a link to the website where the changing places are, giving people access to exactly where those locations are. That would be great.
Yeah,
if not, we can always include it in the content anyway that we're going to send them.
There's an outstanding question in the Q&A box. Any tips on working with families who have not come to terms with their child having a deteriorating condition?
Yes, I can only tell you what I have done in the past, and that is, rather than, if it's becoming clear through the assessment that the parents or the family is struggling, then what I do is I get them to plan for bad days, good days and bad days. So instead of saying, you know, that your child is going to deteriorate, so, well, if they were having a bad day and they weren't able to do this, or even if it's just a short-term situation where they're struggling with an activity for a very short-term reason, we need to plan for those bad days. So that's a way that I have addressed it. But yeah, obviously it's an issue, and sometimes it takes a coordinated multidisciplinary approach with colleagues. But if I get the referral and they're quite early on in a journey, and it's a recent diagnosis, that's probably how I would approach it. But yeah, it is time, and I think it does take a coordinated approach, definitely.
I think that's a really good answer to what is a very tough question, because it's so individual, isn't it? It's but it is a real challenge, obviously.